My assignment, and I assigned myself because it's what was left over from the others, is going to be a potpourri of updates in adjuvant and neoadjuvant therapy, as well as molecular predictors of benefit. So first, a third of the talk will address adjuvant therapy, new results from San Antonio, and then others brought in that have happened in the year. There is one new adjuvant study, which I'll discuss in the context of an important ASCO paper. And then I'll review with you briefly status of trials testing the need for chemotherapy if ER is positive and HER2 is negative, and then also studies in HER2 positive disease that may report soon. And then briefly review 3 new extended adjuvant endocrine therapy trials that were presented. So as you know, incremental survival gains have been seen over the decades from first to second to third generation phase 3 trials. I'm not going to read all these, you're familiar with all of these, and many of you here have used these regimens to where we are now for patients with higher risk disease, where we consider third generation regimens. And the results and outcomes from these various adjuvant trials vary by subsets for HER2 plus, triple negative, proliferation grade, and ER status. But the question that's been out there for quite a while is, can you avoid the A in TAC and get away with, so to speak, TC for 6 cycles and still have that third generation extra benefit that you see with all of these others? So this year at ASCO, Dr. Blum and colleagues presented the important results of the ABC trials, where various third-generation regimens were here with the taxane, anthracycline, and cyclophosphamide regimens that we're all familiar with and use, compared with 6 cycles of TC. This randomization analysis was designed to prove the non-inferiority of the non-anthracycline arm. But it did not prove that. In fact, it is actually inferior overall to avoid anthracycline in the entire trial. However, when you look at it by hormone receptor negative and hormone receptor positive groups within these trials, you can see that for the node negative disease in yellow, you can basically get a similar outcome by avoiding the anthracycline, whereas down here in 1 to 3 nodes in blue or 4 or more in orange in hormone receptor negative, you do need the anthracycline to see your survival benefit. But in hormone receptor positive disease for both node negative and 1 to 3 plus nodes, actually the outcomes are very similar, and an anthracycline might be safely avoided. Now, over the years, we've thought about another marker for anthracycline necessity, that being the status of topoisomerase II abnormalities. And the Danish reported the single new adjuvant trial results at San Antonio addressing this question: does the TOP2A status solve this anthracycline or not dilemma? So their READ trial had one group where in the Danish population, they believed that altered TOP2A must be treated with anthracycline, so there was no randomization in this group. And what's being reported at San Antonio is the randomized group for normal TOP2A of 3 cycles of EC, followed by 3 cycles of docetaxel, versus 6 cycles of basically TC, docetaxel Cytoxan. And what they found was there was no benefit to anthracycline-based regimen in the TOP2A normal population. So perhaps if this can be validated elsewhere, we might have a marker to help us learn which patients at higher risk but with normal TOP2A status might be able to avoid an anthracycline. But here again, the cycles of TC, just as in the ABC trials, were 6, not 4. So if you're going to do this, please bear that in mind. The big question, of course, that we really need answered, and we want it answered sooner than it's going to be answered, is what to do when we have biomarker molecular tools in the intermediate range, whether or not to avoid chemotherapy, or in node-positive disease, whether or not to avoid chemotherapy. These are the big trials you're familiar with, TAILOR-X and the responder. Hopefully, in a year, we will learn the results of the randomization in the intermediate group between chemo or not and TAILOR-X. Responder is finishing out accrual right now in France. It's completed its accrual in North America, and the first interim analysis is expected 1 year from now by the DSMC. SWOG 1207 tests post-chemotherapy high-risk patients, the addition of everolimus or not, and that's going to be a while, as is this trial testing palbociclib, as Dr. Rugo alluded to earlier. Well, what is happening in HER2 space at San Antonio in the adjuvant setting? Really not that much, but we did have some important results. We learned about some important results regarding the Extenet trial, which is adjuvant neratinib after completing the adjuvant trastuzumab. This was, of course, published for their first data lock results in Lancet Oncology earlier last year. The 3-year data were presented at San Antonio with an intriguing interaction reported by hormone receptor status, that the benefit to neratinib was seen only in hormone receptor positive disease. But what is exciting is that the interim 5-year analysis was sent to the FDA for filing and is public in July of 2016, and a final analysis planned next quarter, where we should see at a meeting late next year these 5-year data. And then I'll say a word about the neoadjuvant space for neratinib shortly. But this is the results that went to the FDA a few months ago for the 5-year data, and the absolute benefit reported here for the manuscript is obviously stable and continuing out to the 5-year point with significant improvement. And here is that, again, intriguing data about the hormone receptor status interaction, where the benefit appears to be only seen in the ER-positive group in the trial and not in the ER-negative group. Of course, there were some big trials that have been closed that are going to report out, but the one that we will hopefully hear about at ASCO is the pertuzumab addition to chemotherapy plus trastuzumab phase 3 study to see if the Neosphere results in the neoadjuvant setting, which were very strong, will be borne out in the adjuvant setting. Going on then to extended adjuvant hormonal therapy. This is an area of increasing, I'd say, muddiness. It's muddy. It's as you'll see, the trial designs are becoming very different, and I will show you what was presented at San Antonio, but I think this is a very critical paper that was presented at ASCO by the Early Breast Cancer Trialists Collaborative Group for patients who are hormone ER positive, who've had 5 years of tamoxifen, so we're down here. And this is by nodal status and tumor size. Over the next 15 years, just for T1N0, 14% chance that there's going to be a distant recurrence, and you can see how it goes up after 5 years of tamoxifen. So it's a problem we all face in the clinic, isn't it, dealing with late recurrences. So what did we know about extending adjuvant endocrine therapy beyond 5 years as of last year before San Antonio? Well, we knew that after stopping 5 years of therapy, there was a prolonged carryover benefit lasting 10 to 15 more years. Overall, 5 years of an AI is better than 5 years of tamoxifen. We knew sequencing tamoxifen in an AI, or vice versa, as they did in the Big 198 trial, is an acceptable alternative to 5 years of an AI, and that 5 years of an AI after 5 years of tamoxifen is beneficial. But there was an uncertain role for extending the AI longer after the AI was given for 2 to 5 years in the first 5 years. You never knew quite what to do. So 3 trials with different designs on extending the AI therapy were presented at San Antonio. And these are the 3. I'll show a summary slide next, but I'm not going into them all in detail because none met their primary endpoint significance. And I urge all of you to go to the website and take the time to listen to Michael's excellent discussion of these 3 abstracts, and I thank him too for sharing his slides, which is here, an enormous amount of work just to make this slide, as you can imagine, showing all of the trials. The trials in light gray have not yet reported. The trials in plain bold have reported, and all have been significant with the hazard ratios shown here for an extension of the endocrine therapy. The 3 trials, the NSABP B42, the data trial, and the ideal trial are the new ones. So you can see the designs here were different. B42 most mirrored MA17R in that the letrozole was 5 full years of therapy after either 5 years or tamoxifen and some AI. And this barely missed significance due to the multiple looks on the data, but did meet significance actually for distant recurrence. The data and ideal trials were a shorter duration for the data trial with tamoxifen for a few years, and then shorter or longer anastrozole, and then 3 eligibility possibilities here, as you can see, with shorter versus longer extended therapy. What was sobering in all 3 of these trials was the compliance, and we know it's difficult for 5 years, right? Well, it's basically running, depending on the trial, patients 57% to 74% in ideal, in NSABP 62% of the placebo and 60% of the letrozole completed their extended therapy. So again, what we're doing, we're seeing not even what we think we're seeing as the results. And it's sobering, and perhaps Dawn will be saying more about this in her talk. But if you look at all of these trials, the ones that reported and these new ones, without showing you all the data, you'll just have to take my word for it, but subgroups that might benefit vary by trial, but include a node-positive cohort in a prior chemotherapy, prior tamoxifen, shorter time without the extended therapy, in other words, a less of a window before you start it, bigger tumors, luminal A status, and then the big question, what about high genomic risk? And I'll come back to that later in my talk. But this is Dr. Ganant's conclusion slide from his discussion. What are we going to do in the clinic tomorrow? In his view, and I would tend to agree, that for a patient after 2 or 3 or 5 years of tamoxifen, it's important, assuming they're of a decent enough risk for longer, later events, is to add an AI for 2 to 5 years based on the trials to date. And for a patient who's had all the AI first, then you have to think about the pluses and minuses to continuing, which include tolerance, toxicities, risk by clinical path, more luminal type, and then this whole issue about the genomic tests, which I'll come back to during the molecular section of the talk. So stay tuned for that. Going on then to neoadjuvant therapy results at San Antonio, I'm going to say a word about I-SPY 2. It has randomized over 1,100 patients, of whom 1,000 nearly have gone to the surgery. Remember, I-SPY 2 is adding novel agents with safety data in pilot studies into the standard of care in the neoadjuvant setting of taxane and AC-based therapy. I will also cover non-chemotherapy approaches a bit and talk about the trials for high risk after neoadjuvant therapy. So in I-SPY 2, last year at this meeting, I reviewed the positive results for the buliparib, carboplatin, and neratinib arms in I-SPY 2. You heard something about the metastatic studies earlier this morning. And now these 2 trials have been published in the New England Journal, same issue, by Drs. Rugo and Dr. Park. We have followed on from these results with 2 studies. First of all, the brightness trial is actually closed and hopefully will be reporting soon. This is the mirror to the metastatic trial that Hope discussed, where the veliparib carboplatin placebo, or just the paclitaxel in all 3 arms are compared in the neoadjuvant setting, intended to see if the I-SPY 2 results can be validated in a larger randomized trial. And then for neratinib right now, a phase 1 to 2 trial is ongoing with the 4 drugs together, neratinib added to PTH. And hopefully, if this is safe, there is a plan to test it in an I-SPY 3 validation design. And then we have presented at AACR this year the paclitaxel, trastuzumab, pertuzumab, and the TDM1 plus pertuzumab with no paclitaxel, both graduated with marked increase in PCRs and obviously are going on to larger trials. And other agents in the trial have been completed, which did not graduate, one due to no efficacy here, and then this one had toxicity. And ongoing is pembrolizumab plus paclitaxel, another PARP inhibitor, talazoparib plus irinotecan with no taxane up front, and then patritumab, a HER3 agent plus taxane, has just entered the trial. The Germans are also testing Gepard Nuevo, a randomized neoadjuvant design. This is in German. I'm sorry I could not find it anywhere online, the schema in English, but you get the drift here that there is the MedImmune anti-PD-L1 drug or placebo in the taxane group here, and then on to anthracycline, cyclophosphamide. It's a very similar design to I-SPY 2. This has just opened. Going on to the issue of, in the neoadjuvant setting, of dural HER2 inhibition, we have known all along, since these trials were reported a long time ago, that the PCR rates are much lower in the ER-positive, HER2-positive group than the ER-negative. So Energy NSABP B32 was designed with the hypothesis as to whether simultaneous targeting of the crosstalking between the HER2 and ER pathways would increase PCR in the HER2 plus ER positive group, or is it true that you might have an antagonistic effect of targeting ER while you are giving this anti-HER2 therapy? And the answer is happily no worse, but not significantly better. This was a disappointment. There was no increase, but a lot of good biomarker work is ongoing to determine if there are subsets, in particular by the intrinsic subtypes, for example, HER2 enriched in this particular trial. But another study yielded some very intriguing results, and this is the Pamela Trial, also looking at whether the PAM50 intrinsic subtype could serve as a predictor of past CR following neoadjuvant dual HER2 blockade without chemotherapy in HER2-positive breast cancer, with the hypothesis that the HER2-enriched intrinsic subtype determined by the PAM50 or nanostring benefits the most from dural HER2 blockade in the absence of chemo. And does it provide independent prediction beyond being ER plus or negative of achieving a past CR? And both of these hypotheses were borne out. This is an elegant presentation by Dr. Pratt, and I don't have time to go through it. This is the design where lapatinib and trastuzumab were given, and biopsies were done at week 2 and week 6. What is intriguing here is what happens with the intrinsic subtype distribution by PAM50. This is the baseline, so again, you see the HER2 enriched in pink, but you see all these other subtypes as well. And at week 2, a marked shift to the normal-like type, which tends to have the highest PCR rates in previous studies. And in a multivariate analysis, if you just focus over here, it's 2 variables actually. The hormone receptor status is still independently predictive of whether a past CR is achieved, but the intrinsic subtype, having a HER2 enriched, has a much higher PCR rate compared to the non-enriched. And so this is our newest biomarker apart from this to perhaps use in our neoadjuvant studies to monitor effects of new anti-HER2 based therapies. And then Dr. Rugo covered Neo-Monarch in her metastatic talk, but this was a pre-surgical window study. And just suffice it to say, just like in the metastatic trial, the abemaciclib, the CDK4/6 that functions differently than palbo or ribociclib, in and of itself shows a marked change at week 2 in the Ki-67 and cell cycle arrest. No difference really when combining it with an AI at week 2, and I'm sure this trial will have much more follow-up down the road. But again, a pre-surgical window study informing how to follow these agents in larger trials as biomarkers. So after neoadjuvant therapy, we always have a problem, don't we, in clinic with the residual disease problem issue and not knowing what to do, and we still don't know what to do, but we have trials addressing. Penelope is accruing well internationally in ER plus HER2 negative disease, randomizing between endocrine therapy or the addition of palbociclib. In the HER2 space, the NuVax trial, which is a HER2-derived peptide vaccine with trastuzumab, is ongoing, and the DSMC has just met and announced the trial can remain open to additional accrual. And then in the triple-negative disease, there are many studies, of course, going on with residual disease, but this one in particular, SWOG is chairing in conjunction with Energy, and pembrolizumab is being tested against observation. And so we encourage all of you to participate in these trials. We have them all open at our institution if any of you in the city are interested in collaborating with your patient. And then we have no new data on the platin story or capecitabine story. I spent a lot of time on this at the meeting last year. And at that time, we had this trial open with an observation arm versus cisplatin or carboplatin after standard neoadjuvant therapy in triple-negative disease. That's basal-like by PAM50. And what has happened is that this design is no more. The observation arm has been replaced with capecitabine. So we have no control arm in this study, unless you believe that capecitabine should be given to everyone in this space based on that one trial still yet not published from Asia. So this will be an interesting with 2 experimental arms. But Energy and then the Pearly study are both ongoing phase 3 trials testing the carboplatin addition question. So still we have no standard recommendations for the use of these agents when there is residual disease. Now the last portion of my talk will address molecular predictors. First, some leads from neoadjuvant and adjuvant trials, the adjuvant node positive controversy, multi-gene assays updates, and this whole issue about using them to predict benefit of extended therapy. So for the 70-gene signature, or MammaPrint, we're used to high versus low risk, but know that there's also what's called an ultra-low risk and an ultra-high risk, or MammaPrint 2. So we have 2 reports on each of those extremes of the prognosis. This study presented by Dr. Esserman at San Antonio looked at the ultra-high risk group, the low risk but not ultra-low, the ultra-low risk, the low but not ultra-low, and then the high risk. In the Stockholm older trial of tamoxifen versus no tamoxifen adjuvantly. And here you see out to many years, 20 years, the excellent outcomes showing that this particular group can identify indolent lesions of epithelial origin that may not need more than 2 years of tamoxifen or even may not need anything except for preventive reasons. And then on the other extreme, the ultra-high risk, remember the I-SPY 2 veliparib carbo biomarker study showed improved prediction, showed graduated, which is here, increased past CR rates with veliparib carbo versus control, which led to the validation trial that we're waiting results. Here, for MammaPrint ultra high risk, or for a PARP inhibitor sensitivity signature, or for BRCA1-like signature, you can see that for these 2 in particular, and then when you combine these 2, MammaPrint ultra high and the PARP inhibitor sensitivity, past CR rate approaches 80% with the veliparib versus 23% with the PARP, and the dual signature versus if those signatures are low, you don't see any difference from the control arm. So looks like we may have a new marker to monitor going forward in larger trials. Then the IBCSG continues to do good work on their trial with their biomarker platform. Here, the objective was to evaluate the prognostic and predictive abilities of somatic alterations in postmenopausal early-stage breast cancer, presented by Shireen Loy. And I cannot go through her talk in detail. This is just one of the most intriguing results that she found, is that the PIK3CA genotype, excluding 11q amplification, has an interaction with treatment. So what is seen here is that if you are PIK3CA mutant, there's an outstanding result with letrozole versus tamoxifen, whereas there appears to be, if anything, a bit better with tamoxifen if you are wild type. So this is intriguing and maybe another way to help select therapy up front as you begin adjuvant endocrine therapy. Going on to the node-positive controversy, should you use multi-gene assays to help treatment decision-making? This is an important paper presented by Petkoff et al. From the SEER group, published in Nature's Breast Cancer Journal earlier last year, showing just for the node-positive group, a large node-negative group validated what we've known about the prognostic utility of the recurrence score. Node-positive, though, 1% breast cancer-specific mortality at 5 years. Most of these patients were not treated with chemotherapy in this low recurrence score group. So this group went on at San Antonio this year to look further in this database because of the concern that maybe it's just the grade that's playing out, but it is not. If you look at down here in node-positive disease, the smaller tumors with high grade or the larger tumors with high grade, if there's a low recurrence score, the outcome is almost perfect with no events occurring in either group. So the recurrence score is being validated in node-positive disease. And what Dr. Terry Mamonis did, and with a group of us who had shared trials in node-positive disease looking at the recurrence score, came up with a poster looking at the issue because right about the time of the San Antonio deadline, and ASCO came out with their negative recommendation not to use the recurrence score or any other molecular tools to predict use of chemotherapy in node-positive disease, counter to what NCCN continues to state that it can be used and considered in 1 to 3 nodes. So here you go. These are all the trials, so you can look at this on the web if you're interested in this field with all of the results. But the bottom line from Terry's poster is that the total body of evidence is supportive of the latest NCCN guideline that states that the assay can be used or considered in 1 to 3 plus nodes and chemotherapy safely avoided. Part of the issue was the ASCO guideline committee did not have all of the data that was shown in the table on the previous slide when they went into their guideline work. And so we still believe, at least those of us on the poster, that patients in this situation should still hear about the pros and cons of getting a recurrence score if there are 1 to 3 positive nodes, because we're still going to wait probably 2 years at least, or maybe 3, to learn about the results prospectively in responder. Now in SWOG 8814, which was a trial that led to the use of the recurrence score in 1 to 3 positive nodes so far and led to the design of the responder trial. Remember, that's CAF followed by tamoxifen versus tamoxifen alone. We reported last year at San Antonio using whole transcriptome RNA-seq, sequencing 20-some thousand genes, that we defined many pathways that were good for prognosis and prediction. But we didn't have much in there for late events, so in this new analysis we did several things. We've departed from DFS and now have been able to review all the charts and have breast cancer specific events. And I'm going to show you first the data for tamoxifen prognosis and prediction of CAF benefit and come back later to the late event story. So here you see, using the 5 metagene model we developed from the axonic work, you can see that there is an excellent, like nothing happens, low numbers, but in this group, up to 12 years, no events, whereas, and these are all node-positive patients, whereas in the high multigene, high metagene group, there is definitely events happening. But more intriguing yet, recapitulating results from other types of studies, including back to Soon Pake's work in node-negative disease in the low-risk group, here using 3 metagenes, where you predict the 10-year risk is less than, we divided the metagenes with a cut point. There is nothing happening here, which is good. This is the tamoxifen group, though, not the chemotherapy group, whereas the chemotherapy group is doing worse. And over here, for the high-risk group, the chemotherapy group is doing better. MIND-ACT, of course, created a big excitement this past year with the publication in the New England Journal. I do not have time to go through this trial now, but suffice it to say, the clinical low-risk, genomic high-risk, and the clinical high-risk, genomic low-risk group were randomized to chemotherapy or not. And the primary endpoint of this study was really not this question, which I think a lot of us did not realize. The primary endpoint was that the integration of the genomic signature permits identification of a cohort of ER-positive tumors with good prognosis, quoting Hal Burstein's AACR discussion this past year, with a 95% distant disease-free survival. But interestingly, this is the high genomic group, high clinical risk, low genomic risk group. They had a chemotherapy benefit, which wouldn't have been predicted, whereas the clinical low, high genomic group did not. So what's very important, that's showing this here, this is not significant, but this is something I have just learned, why this is so puzzling over this. The MIND-ACT trial was not designed or powered to discuss prediction. And so if you order, any of you who order MammaPrint, you get it back, and there's a disclaimer there that says this should only be used for prognosis. So bear that in mind. I think still the recurrence score is the most robust data for using it for prediction of chemotherapy benefit. Now, the 21 gene recurrence score also discriminates prognosis for late outcomes. I'm going to move into the late outcomes, last section of my talk right now. Here is a paper published this past year by Norman Woolmark in the NSABP, showing that if estrogen signaling is high, here you can see that there is a definite good outcome for the low recurrence score group. Whereas, if it's not, for late events, so backing up, sorry, this is 5 years and out, and this is the early time period. So it's very good to see that if you have high ESR expression, perhaps the luminal A's, the recurrence score is giving you late events. It's not true that this assay does not provide late event information, but it does not in the case of low ESR expression. Breast Cancer Index is another tool that's out there that, without going through all the details behind the assay, you can look at my slides. Feel free to ask for them. But 3 trials, very nice design, show that this is a prognostic tool for early and late, going all the way out. But there's also a predictive tool that you can order that states that you can determine whether or not you will benefit from extended endocrine therapy. And this is where the big controversy is right now. The data for prediction of extended adjuvant therapy with this tool is based on a nicely done retrospective cohort study on MA17, which was the AI followed by 5 years of TAM. And for the high index, there is a benefit, and the low index, no significant benefit. The problem is this does have to be validated on these extended adjuvant trials we just reviewed on that summary table, and that is underway. There were other aspects presented at San Antonio using this tool for decision making, and they've also developed an algorithm that adds clinical features to it to enhance prediction and prognosis. Others that are good for prognosis over time are PAM50, and EndoPredict with clinical features added. And what created all the stir at San Antonio was the oral presentation by Dr. Sestak et al., comparing the prognostic performance of 6 signatures for distant recurrence in N0 and N plus disease in trans-ATAC trial, so that was an AI versus tamoxifen trial, postmenopausal women, no prior chemo, and 5 years of endocrine therapy. And these were the signatures that were looked at in this analysis. The ones with the green arrows have clinical features added to it. They didn't use the recurrence score clinical feature tool for some reason. So there's a difference in these signatures. And this is a very complex presentation with a lot of bioinformatics. So Sue Hilsenbeck, a biostatistician at Baylor, was chosen to be the discussion. Her discussion was outstanding, and these are her conclusions. That for any recurrence 0 to 10 years, all of the signatures identify really low-risk node-negative patients. But the PAM50 ROR and EP-CLIN can identify some low-risk node-positive patients, but I believe the other assays do as well, can do that. They were just not included in the analysis, perhaps correctly. But for late recurrence, what we're really interested in, the results are qualitatively similar, but predictive power of some signatures degrade over time due to time dependence. Clinical variables seem to be important, at least in determining risk, but what we don't know is how to best blend the signature and clinical data so that we know which patients with high enough risk should we consider chemo up front, or should we consider adjuvant extended therapy? And her conclusion was we don't know that yet, so it may be premature to use these tools for predictive. And I actually agree with that. For example, it would have been nice to have seen the recurrence score pathological clinical, which is existing for the recurrence score in an analysis like this. But as of yet, there is no evidence that very low genomic risk but high clinical risk benefits from added chemotherapy. There is concordance and clinical utility across all tools that a low late risk might avoid. So this is where I think we have some confidence now with any of these tools. If you have a low late risk prediction, you might be able to avoid extended adjuvant therapy with endocrine agents, but a prospectively trial is needed to prove that high late risk will benefit from more of the same drug. Just very quickly as I conclude, the other part of our SWOG new analysis presented at San Antonio was developing a whole gene transcriptome approach by looking at the introns in between the exons to define the whole gene, and then we came up with a whole gene score. Just one summary slide from that, using finding a low probability of breast cancer-specific events after 5 years of tamoxifen in 1 to 3 positive nodes with a low risk score. So again, we're seeing more tools that can predict that outcome. So new research directions are needed to prevent late relapses in genomically defined high-risk groups. One question is, will the SERDs, CDK4/6 inhibitors, mTORs, PI3 kinases prevent late relapse if given up front, or should they be introduced at the end of 5 years if there's predicted high risk? What about growth factor inhibitors, immunotherapy, and all these other pathways on Dr. Ganant's last slide? Certainly it's the stem cells we heard from Suzanne this morning that we really need to target, and I think there are exciting days ahead for this particular field. Thank you.